Namaskaram. I am Dr. Sivasankar Dalai. I am Chief of Neurovascular Intervention at Medicover Hospital, Visakhapatnam. So we have an interesting case today. He is a 51-year-old man, a known hypertensive and newly found diabetic, presenting to us with a complex type B aortic dissection. So we have planned for a hybrid procedure. The procedure is a surgical bypass of the left carotid to the left subclavian, followed by grafting the type B dissection. Let's look at the images. Sunil will help us to understand the images. You can see this is the aortic arch. This is the largest blood vessel in the body, and this is the portion of the heart. The heart will have a left and right side. Left side has a pure blood. The pure blood from the left side will go to all parts of the body through this aorta, that is a large blood vessel, and the first uptake will be going towards the hand and the brain on the right side. So right hand, then the right brain, and then the left brain and the left hand, and then comes down. Here if you note, this aorta is dissected. Can you pull it back? Pull it down. Yeah, that's good. So you can see that the aorta is dissected, and the dissection is further progressing. You can see this dissected segment and non-dissected segment, and this is basically the false lumen and the true lumen. So what I am trying to explain is basically aorta is a very large tubing which will take the pure blood from the heart, and that will go down inside the chest, inside the abdomen. Then it will divide into two and go towards the leg, which are called the iliac arteries. And now the first branch from this aorta will be a carotid artery or the brachiocephalic artery, which just will divide, and one will go towards the hand and one will go towards the brain on the right side. And then it continues and it gives to the carotid artery onto the left side. Here the right and left carotid both are coming from the same, which we call as a bovine uptake. And after this branch 1, branch 2, the third one will be subclavian, which is going towards the left hand. And now here the dissection has just started at the level of the left subclavian artery. Dissection means this large tubing have multiple layers inside it. So the blood has dissected and it has separated the two layers of this tubing. And because the false lumen is having only one single tubing, so it has a very low pressure, the blood starts gushing into the false lumen. The false lumen continue to become large, and the true lumen gets compromised, and this is what is happening here. And we will go and do an angiogram here first, then we will start doing the graft. The surgical bypass part has been done. Can we go with the word here? So we have a large team of people very experienced in doing this hybrid procedure. Table, please. Slow. Table, please. So we are exactly doing what it is required. Table, please. Table, please. So we have gone from the left side, and at the level of SMA, that is about the L1, we have turned ourselves into the left side, and then we have gone, and we will do a little check here before we progress further. Can I have the screen closer to me? All right. All right, Sunil? We have the right renal, which is from the true lumen. Table, please. Sunil is still in hangover after the Kalimpong. So you can see the lumen which is very much compromised, that is true lumen. True lumen is always compromised. Why? Because when the blood gushes through a dissected lumen, the false lumen will have less resistance. That's why it will take more and more blood and it will become dilated. Once it becomes dilated, because the aorta is not yet ruptured and contained in one vascular space, it will compromise the true lumen. Okay, beta? You see this? Very small aorta. That means true lumen. Okay? Yes or no? Table, please. So, Sunil is a very good friend of mine from Life Tech. So, he has his own style. Okay, happy? Super happy? Great. Sunil is happy. The plus superstive दे एक pigtail दो एक run ले लेते हैं. So today we have Parvati, who is again super fine as usual. Suddenly she will look white before a good procedure. She will go and apply a lot of talcum powder, something. She has a secret which she is not sharing with us. And we have Prashant today because Prasad is enjoying his life in Bombay for the India Live at the Reliance, Mumbai. And then we have Gauri. And then we have the stylist Sinu with long hairs. Thankfully, he is putting his cap. Then we have Dr. Vipul from surgical side. And Dr. Padhi, who has done all this bypass, is going to join us, my big brother. And who else is there? Dr. Vipul can introduce the surgical team. हाँ क्या बोल रहा है बेटा? हाँ Okay, that also we can do anywhere near the true lumen. Ready? तो भाई आसन तू. So Bhai will give a brief surgical introduction to the case. So as I told that we have been doing this complex hybrid procedure. What is a hybrid procedure basically? Hybrid procedure will have a part 1 and a part 2. Part 1 will be a surgical procedure and the part 2 will be an endovascular procedure. And basically we have been working for more than 10 years, Padhi Bhai and me. And we have our operating area in the same floor, very close to each other. And so we plan the case in such a way that we just follow through. So the surgical procedure will be done immediately. Patient moves into the cath lab and we just finish the procedure. There is no time lag. So Bhai is here. So
good evening. I am Dr. Karunakar Padhi, cardiothoracic and vascular surgeon. And we are going to do this complex hybrid procedure. The patient has come from Bangalore. Actually, he had a acute type B dissection and he was trying to fly back to Bangalore, but because of breast sickness we advised to stay here, and this requires emergency operation in the form of a hybrid procedure, because this dissection has started from the subclavian artery, left subclavian artery. So we have done surgically a bypass from the left carotid to left subclavian.
Excellent.
And now we are going to put an endovascular stent, and Dr. Dalai is in action. He is an international figure.
15 ml per hour.
We are going to do our best for this patient.
15 ml.
And this is very complex in the sense the dissection has
20
extended till the iliac artery. So
600 psi.
We have to do it very meticulously and carefully, so that stent will be at proper place. And the anatomical variation in this case was both carotids are almost arising from the right side, so it is like bovine arch. So we have lot of space to keep the stent between the left carotid and left subclavian. So
Exactly, we had about 22 millimeter, which is adequate for us, and the bypass has been done so fantastically well. We had a very quick cut down, but actually the patient is having a lot of fat, little on obese side, but this was greatly done. And let's see, we will go through the femoral right now, and we will put our bot, one bot and terimo. 5 minutes taraf.
Give mustard.
Light.
Table can go bit down.
Oh yes, table down please. Stable, stable. Okay.
Very deep.
Where they sit there? Well, there, ready con. Put the short wire, short J knee wire, put it here. 6F short sheet. That's all. Don't touch it. Yeah. So we have exposed the right femoral artery,
Needle.
which is a little deep. You want to put the umbilical tape distally?
No, sorry.
Okay. Take.
That will be. And that symmetrical patient.
Can I have the bot and terimo? Bot and terimo.
After this, whether to do or not, to decide. If AF related low EF, I think we can do like yesterday case.
So this basically these aortic diseases are becoming more prevalent even in younger age because of smoking, stress, hypertension, and the other related.
Gone, no? Through the
Yeah.
Sunil is happy?
Yes.
Sunil beta, are you happy?
Yes,
So
this is a challenging situation because sometimes when the dissection goes till iliac artery, dissection of common femoral sometimes may occur, but this case it has not gone there and we could able to directly enter into the true lumen.
all right. Land quest.
Plugging required or not required?
For the
subclavian.
hold the seat by it. We can put a vascular plug at the origin of the subclavian, looking at the vertebral artery distance.
Vertebral distance looks reasonable.
Out. All right. But I allow 30.
5, 7, like watch on that.
Table please. Table up. Mac taku. Taku. Inka taku. Inka taku. Okay. Table. One mag. All right. I will request for apnea. I will request for apnea. So are we ready? Everything is okay. Yeah. We have the land question to take the graft which is sitting just at the aortic root, and then we have the pigtail which is just above the aortic root, just before the innominate, and everything is right. Everything is ready. Table, please. Okay. Beta, go there for the injection. I request for apnea in 1 second. Are you ready, Prashant?
Yes, sir.
Both are Prashant. Dr. Prashant and Hero Prashant. Are you ready?
Ready, sir.
Okay, apnea, please.
It's coupled.
Okay, no problem. That's okay. Ventilate. So it's a beautiful picture and beautiful graft.
What is this white black coming?
White black because the injection was done before. So you can see the dissection and the false lumen. Our catheter, everything is in the true lumen. That is very well seen. Baba, happy?
Yes, sir.
हाँ, happy सिंग हो जाएगा भाई ज़्यादा happy होने से. Happy. That is where we will do. Okay. That is because of DSA. Now that's a good question. Why there is a black and white? So basically we do a DSA. DSA means digital subtraction angiogram. That means whatever we see on the screen, we take it as a mask. We take it as a basic thing, and what we inject beyond that is shown. Now, for example, during taking of the mask, we have injected the contrast because of the auto connect of this injector. Then the contrast will be also identified as a native, and it will also be negativized. So this is what is happening. The injected contrast before the mask was taken looks white, and after the mask the contrast which is looking black. So this is getting us a very beautiful picture, which is a true lumen, which is a false lumen. So because we have injected previously, now the true lumen is seen as white, the false lumen is seen as black. Okay. So that is the beautiful image we have got. Now we'll go ahead and deploy the graft. Can you just lock the table? Table locked. Can I have the screen closer to me? Table lock cheyandi. Bring the screen closer to me.
So I'm opening the device, sir.
Yes.
3228 200.
Yes. So now we have absolutely no doubt that we are in the true lumen. It's a very, very important thing. For example, you have put your graft in the false lumen. This is going to be major catastrophe because you are going to have an aneurysm over there. Very difficult to treat. So the trick here is to go from the true lumen, through the true lumen, into the true lumen. So we have seen people grafting the false lumen, going up into false lumen and getting nowhere. That is going to be a problem. So here we see it very clearly. Up. हाँ
Side put 20 cc.
हेला रे 10 रे 3 थर पूरे लावन कर बापा easy to inject na. If you are injecting with the 10 cc it is easy to inject
Suction.
and you use less plastic, right?
Less plastic.
Another syringe is not used.
Suction connect to
Yeah. So we just activate the hydrophilic coating.
throw that you can suction somebody can connect.
Stay away very. Don't touch that part, this part of. Okay, bhai?
Yeah.
Can we take out the seat?
Wait, let me have
If you have a clamp,
I need a suction.
it is not working.
Where is yeah, they are connecting it.
Connecting. Okay.
ఈ లైట్ ఆన్ చేయలేదు.
ఏ భాయ్ కా హెడ్ లైట్ ఆన్ చేయండి బాబా. ఓకే గుడ్ గుడ్.
సో ఇది ఒకసారి రిట్రాక్ట్ చేయము. ఇట్స్ కమింగ్. ఎనీ వైర్ ఇస్
So I remember that case we were doing in Kolkata in BM Birla Hospital. I was doing that in a late evening. That time there was a lot of struggle to go from the true to true because there was a large aneurysm sitting in the thoracic aorta also. So because this dissection has progressed and become very large, and so we put 3 grafts, and that day I think we started about 7 o'clock in the evening and it went on up to 10. Yeah, I remember the seat right. You have a clamp? Huh?
These clots may get pushed with that. Suction working? Okay, now we can remove.
Okay.
Remove.
Sorry. Keep it away, it will become bloody. Okay, bhai, holding. Can we have the graft going in? That's perfect. That's well. Very careful about it. Yeah.
So fix the wire, sir.
Now remove it.
Stop, sir. Stop.
Bada, team anesthesia, we will request you for reducing the blood pressure now. The systolic can come down to 80.
Device, sir.
Huh?
Take this 8 marker into the.
Yeah, we'll take the spine into the lateral side.
Perfect, sir. Ma'am, fix the wire, please.
Madam Garu,
Slightly pull back.
just a minute. तुम्हारा रोड मैप कहाँ हटा दिया तुम लोग, और एक रन लेना पड़ेगा.
Deep branching wire is a good landmark.
Fix the device, sir.
Yeah,
Fix the device.
ठीक है. We'll take one more run, Prashant beta.
So we'll not cover up too much higher. Take it to center, sir.
No, I am reducing the blood pressure. That's most important for me right now.
Table. Table down. Table.
Just give me a mag. Wait a minute. Give me a mag. One more mag. Take. Sunil, calm down. Sunil, calm down. Okay?
Coupling is off, sir.
ठीक है बेटा. Now, what you do is you give us the oblique, the LAO 30.
Or low. It's 30, sir.
All right. Then, meanwhile, how's the blood pressure doing? We have time for 5 minutes if you want to take time to reduce the blood pressure. And once that is done, we take a final run before we deploy. So, how does what do you think the symptoms of this acute dissection of the thoracic aorta? How do the patient presents?
The typical presentation will be the pain in the back, and patients will be usually hypertensive patients. Any hypertensive patients, if he presents with severe pain in the back, then we have to suspect then this type of type B dissection, and sometimes it will be radiating down into the abdomen and maybe sometimes to the left arm. So, if that is their severe back pain, we have to investigate these patients in this
Run
line.
and close.
Normal CT scan cannot diagnose, so we have to do a CT angiogram which can clearly demonstrate the things. And sometimes if dissection is very severe, we may not get the pulse in the lower limb. That is also a clue that patient might be having dissection.
So, if you remember, bhai, we had a patient who had a dissection. Because of the dissection, patient had renal shutdown,
Yes.
very high creatinine, and lower limb ischemia.
That was our first case.
Yes. So the patient came from Kolkata,
Yes.
basically, and patient was having bilateral severe acute limb ischemia, and the creatinine was around 2.4.
And he was on dialysis.
He was on dialysis.
So actually that was our first case. So we are hesitant to go ahead or not. But after the procedure over, patient started pouring urine and the dialysis was stopped. So it was a very interesting and satisfying case.
No, here. Okay. Okay, beta. So we are ready to go ahead with an angiogram. Prashant, beta. I'll request for an apnea, Dr. Prashant. Okay. Apnea, please. Inject. Ventilate. Stop. Stop. Yeah.
So it has to come there.
Yeah, it will.
Very
Yeah. So, Dr. Prashant, could we make the systolic below 100? All right. Leave that.
okay.
As you see, automatically push over. So we just have to hold our horses.
Take one check, sir.
No, no check.
Partially decline. Okay, 1 second. Slightly come back and we'll go for rapid. Slightly come back, sir. Okay, turn on the trigger and we'll go for rapid. Keep going.
ନା କ'ଣ ଭାଇ ଯୋଉଠି ଚାହୁଁଛନ୍ତି ସେଠି ବସିବା ଦରକାର ସିଏ we wanted the aid to be there, it is there. Okay, Ada?
Yes.
Happy? Kalimpo?
Slightly show down, please. Show down. This line.
Yeah. Table?
It's completely required.
Perfect.
We'll take one
We'll
angio
release the
clear.
nose cone.
We'll take the angio clear. The pickle is already inside.
Just a minute. Yeah. But are you ready for one more run?
In that course, please.
Leave it. Sunil, calm down. Just, you have a flight to catch? No, no. That's relax. Dr. Prashant, apnea, please. Mr. Prashant, inject. Perfect.
Oh,
Okay?
fantastic.
Yeah.
Ventilate.
Ventilate.
Graft is fantastic.
Graft is fantastically flowing.
So plugging thing was not required. Or
Plug it. Yeah, I will keep the wire. Okay. Table, please.
Resheet it. So, sir, come down, sir.
Just it. Just. Yeah, we'll keep the wire. All right.
release the pigtail and put it in.
Yeah, we'll put the pigtail inside the graft and then we'll take it on. Can I have the Terimo? Hold it here. Table, please. Table, please. All right. So I would say that Parvati and Gauri are doing some fantastic work here. They have been really the backbone of the department. And we are sorely missing Prasad, but Prasad is not missing us because he is enjoying in Mumbai, right? So we had an FMT professor, Professor Ratnakar Das. So in his language he'll say, this bugger fellow going to Bombay and enjoying, not studying in the conference. Bujhila Papa? Aspirate. Little more aspirate. Not other side, beta. Just do aspiration other side. Bas. Bas. सुनील को जितना दिखता है उस क्या करे वो बड़ा इतना बड़ा आदमी है ना. Okay, are you ready for one more injection? No, this is good. Are you ready for the injection? Dr. Prashant? Dr. Prashant? Table free chair. I will request for apnea, please. Apnea? Inject. Oh, perfect. Thank God. Thank you. Okay, ventilate.
False lumen is not filling now.
False lumen is gone. So true lumen is taking out the beautiful shape. Dissection is completely taken care of. And our graft is starting.
Also not filling.
Graft
So
is starting
plugging
just
not required.
beyond the innominate. It's such a wonderful, such a dream procedure, and thank God. And Bhai has done a great job as usual.
Good.
I think we are coming to the end of the procedure. So this is beautifully done. So we are thankful to God for this wonderful opportunity. Huh?
And all our team members, Dr. Bipul, our cardiac surgeon,
Pagla
Dr.
gaya.
Prashant, cardiac anesthetist,
Why so much of contrast?
Shiv Shankar, our sister Surya.
Table, please.
We'll take an AP.
Huh?
AP.
So the plugging not required, no? Sunil?
No, sir, it's not filling, reverse not filling.
There.
It's covered by the stent.
If required, we can put a plug in the follow-up.
If required.
Yeah.
You will remove
Yeah, we'll close after this one angio.
To AP and DMAT.
one more NG.
Just the distal flow and close. Dr. Prashant,
DMAT.
we will request you for full DMAC beta. Mag taku. One echo. Bas. All right. Table. All right. Apnea, please, Dr. Prashant. Inject. All right.
Oh,
Beautiful.
great.
Chalo.
Everything
you,
from
Dr.
True Lumen.
Everything.
Fantastic job.
Great. Table.
What, Sunil, you are happy?
Yes.
अभी सुनील को ज्यादा हैप्पी नहीं करेंगे.
So your flight is what time?
9:35.
So you have to rush.
No, we can finish 2 more cases. We are coming to Bangalore to play Bangalore Open Tennis Tournament. Yeah, Saturday night. So is it done, right?
Shall we remove?
I will remove if you want, if you have a clamp ready. I'll just keep the wire.
Surya, come. Wait.
No, wire is there.
No, this coming out, it will bleed.
Okay,
This
then just you can take the clamp.
This is first thing. Pattu.
Right.
Give me a clamp, suction, swab. No. 60 ready? 60. Okay. Grand clamp cover. Wait.
Should we give some heparin now?
Heparin given, no?
Give it.
One more clamp.
Prashant, very good. Well done. Good job. Very impressive, every one of you. Stylish, only we can tell whether you've done a good job or not after seeing the recording and the live.
Can you pull it out?
Yeah, bhai.
Along with the wire, you can pull it out.
Everything will be pulled slowly. Yeah. I'm completely out.
Yes.
Thank you, bhai.
Retraction. This is slipping.
So, thank you so much for joining us for this interesting
Dissection
case this
cover,
evening.
yeah.
It was a type B aortic dissection. The dissection was just coming at the level of the left
Dissection
subclavian
cover,
artery, and we have seen that the both carotids are coming out the same. That's a
Dissection.
bovine arch, and we went from the true lumen to true lumen,
Bleeding.
and then we grafted, and everything looks so
Hey,
beautiful.
bleeding.
Thank you so much. Namaskaram.